Hello, and thank you for joining me on this UncLive TV peer exchange. This program will feature expert panel discussions on key topics related to the multidisciplinary treatment of hepatocellular carcinoma. I'm Ghassan Abou-Alfa. I'm Associate Professor from the Gastrointestinal Oncology Service at Memorial Sloan Kettering Cancer Center in New York. And joining me today are Dr. Richard Finn, Associate Professor of Medicine at the Griffin School of Medicine at UCLA, Division of Hematology and Oncology, Dr. Jeff Geschwind, Professor of Radiology, Surgery, and Oncology Chairman at the Department of Radiology and Imaging Sciences at Yale University Medical School, Dr. Robert Gish, Professor at Stanford University, Senior Medical Director at St. Joseph Hospital and Medical Center, Medical Director of the Hepatitis B Foundation, Medical Director of the Asian Pacific Health Foundation, Vice Chair Steering Committee for the National Viral Hepatitis Roundtable, and Vice President of the FAIR Foundation. And Dr. Adam Yo, Assistant Professor of Surgery for the Department of Surgery at the Division of Surgical Oncology at the University of Texas Southwestern Medical Center in Dallas, Texas. Thank you to each of you for joining us today, and let's get started. Let's begin discussing some of the concepts on prevention, surveillance, and early detection. And maybe I'll start with Bob. As an expert in hepatology, no doubt that hepatocellular carcinoma plays an important presence in regard to the highest risk of death from cancer. And as we know, it's not inherited, but rather caused by risk factors. Please take us through those different risk factors.
So worldwide, hepatitis B is #1. And if we want to talk about prevention, we've got this great vaccine for hepatitis B. So from a hepatitis B perspective, we wait 50 to 100 years, we could potentially wipe out much of the liver cancer in the world. But let's come to the US. Hepatitis C is #1. And hepatitis C, we've had huge problems with difficulty curing and also transmission, blood at first and then needle exposure and blood exposure. So if we take down risk behavior and we start curing hepatitis C, we can start changing what's happening with liver cancer in the US. But finally, we've got an epidemic of fatty liver. The emerging risk for liver cancer is NASH, and we're going to start doing surveillance, of course, in our fatty liver patients for cancer. And surveillance is a really important part of what we do in our practice every day.
And obviously, one more risk factor that we still commonly see, even though it's not evolving or changing much, is alcohol and alcoholic cirrhosis. But let me take you back a little bit to the hepatitis C story. And obviously, this is a silent epidemic, has been going on for a while. But I have to say that we are in 2015, but since 2013, we've been hearing great news about Hep C. Take us through what are the new developments.
So what's happened with hepatitis C treatment is we've moved almost 100% to all oral therapy, and we've moved from cure rates of 50% to 95%. And this is going to change the dynamic of getting cancer in the next 10 to 20 years, because all these people are going to be cured. And people who have cancer today, who have hepatitis C, we can treat their hepatitis C at the same time they have cancer and make them better, make their liver function better, make their portal hypertension better. I think it can decrease the risk of recurrent disease and help us manage the cancer better in real time.
And so the best data that we had back, if you recall, the 99s, early 2000s, is that the expectation that Hep C might evolve to a less of an important risk factor simply based on awareness. And there was discussion by Hashim al-Sarraj and others published in New England Journal of Medicine that this is going to decline. Obviously, with the new presence of the protease inhibitors, do you expect that the Hep C-related HCC will almost disappear by a certain time, or what's your expectation on that?
So beyond the protease inhibitors, we have what are called polymerase inhibitors and S5A inhibitors and combination therapies, but there's so much hepatitis C and cirrhosis out there. I think it's going to take another decade before we really see a marked decline. And remember, people with hepatitis C are overweight. They've got fatty liver, or they have alcohol, which we call ASH and NASH. And you sometimes have 3 or 4 diseases in one patient. So we will see an improvement, but it's going to be 5 to 10 years before we see a marked inflection.
And I like what you said, and sadly enough, this is probably the new other epidemic that we're dealing with, which is the one related to morbid obesity as well as to diabetes, and what's related to non-alcoholic fatty liver disease leading to non-alcoholic steatohepatitis, which you call NASH as well. What are the figures?
So if you look at the United States, you have, what, close to 310 million people. We're looking at 60% of adults being overweight, and 15% of those people will get at least cirrhosis, if not cancer. So we're talking about a huge upswing, maybe 50,000 liver cancers a year in the US, 70,000 liver cancers a year in the US by 2020 or 2025. This is going to be a huge problem for society, our patients, their families, managing these cancers, picking them up early. And you imagine trying to treat a liver cancer in somebody whose BMI is 40, is overweight with diabetes. It's going to be very complicated.
It's very sad, and for our audience, especially as medical oncologists, no doubt that probably the distribution at the moment in regard to what you'll see in your clinic is going to be about 30 or about of hepatitis C, 10 to 20% of Hep B based on where you're located in the country, based on the presence of immigrant population or diversity in that area. NASH, you are absolutely right. We're seeing more and more. And what do you think, Richard? Are you seeing more of those patients?
Yeah, for sure. I mean, coming from Los Angeles, which is a very ethnically diverse population, where we have probably more hepatitis B than other places in the country, as well as a very typical representation of hepatitis C, but also a lot of diabetes-related liver cancer. Also, there's probably a little increased risk in the Hispanic population as well, which, given we're in Southern California, we tend to see that. I guess, Bob, one question I would have is, do we know that if you have hepatitis C and you're cured of your hep C, do you stop screening for liver cancer?
So it's a great question, Rich. Screening, of course, is the first test, and surveillance is regular testing. And if you have cirrhosis, you need to have surveillance until that cirrhosis reverses. And we often combine that imaging, if they have cirrhosis or not on imaging, with biomarkers, which we're going to talk about a little bit later. So we're using blood tests and imaging to decide when to stop surveillance. But our rule is a cure, at least 5 years before you would stop surveillance.
And surveillance, just kind of make sure that even though probably medical oncologists are not really the physicians who are going to be in charge of this kind of need for patients with hep C, but what do you usually do? Like, what are the regular tests that to be done?
So ultrasound is still the standard for surveillance for almost all patients, but of course, because of this obesity issue, once your BMI is over 30 or 32, ultrasound quality really starts declining, and then people start alternating ultrasound with MR or ultrasound with CT, and then again using biomarkers to decide when to trigger advanced imaging. Ultrasounds are getting better, but they're still not good enough to get through thick skin and see through fatty liver changes. So this is a real problem, not just for cancer risk, but for finding cancer.
Fascinating. And if anything, when it comes to the diagnosis as well, we hear a little bit about more advanced markers, but take us through a little bit about what do you know about AFP, L3%, and as well as DCP. Are they practical to use? What's the value?
I've been using these two biomarkers in addition to AFP since about 2006 or 2007. So they're FDA approved or FDA cleared. But there's a little bit of an art to using these biomarkers. But we know that 15 to 20% of HCCs have normal alpha-fetoproteins. But most, if not all of those, have one of these other two biomarkers. Not so much for diagnosis, but for early detection. So if you do these biomarkers regularly, it may allow you to do advanced imaging. So really what they are good for is risk for cancer, not for diagnosis of cancer. We turn to Jeff and our radiology colleagues to make the diagnosis.
So Jeff, anyway, this is well-timed, and I'm just wondering, can you take us through the technology component of it in regard to screening from the radiology perspective?
Well, I concur with what Bob said. Unfortunately, we are still relying on ultrasound for most of the surveillance programs that we have and screening with imaging. And the problem with ultrasound is also the subjectivity of it, and that it's very operator dependent. So as a result, it is not the most reliable test that we could use, but it's the cheapest. So we are forced to use ultrasound and to rely on ultrasound for early diagnosis. The other problem is that not only do we have the issue of BMI, but we also have the issue of small-sized tumors. And we know that the sensitivity of ultrasound decreases significantly when the tumor sizes are less than 1 centimeter. So this is the major problem that we face in imaging sciences, to identify these tumors early stage with a tool that we can use reliably. So the guidelines are very clear. If there is any kind of suspicion of a mass in a cirrhotic patient, then you can go to the next level, which is four-phase CT or MRI, and with the hope that those two will identify some kind of tumor reliably. And the criteria have been very well established nowadays. We know that's early arterial enhancement with a late washout on the four-phase CT or MR, gadolinium-enhanced MRI, and that is virtually pathognomonic for HCC. So if we have those features, we know that the patient has HCC.
Sure. So to summarize what we heard so far in regard to surveillance and epidemiology, no question that we have a serious problem going around us. As oncologists, we're going to see more and more of those patients with hepatocellular carcinoma. It's due, as we heard, in regard to the risks of hepatitis C, hepatitis B, non-alcoholic fatty liver disease, and alcohol as well. In addition to that, we heard about surveillance and what it would imply. It seems the basic program will be dependent on ultrasound and alpha-fetoprotein, but we heard from our experts that could be some limitation to this technology that's being advanced based on both on the biomarker component as well as on the radiology component. But it comes now.